Good afternoon to everyone, and thank you for this very kind invitation. Thank you to BD for the opportunity to share during this lunch symposium my experience on using the mechanical atherectomy device, not only in 𝗷𝗴𝗃𝗀 occlusion, but also to understand the use of this device in different scenarios. And also it's an honor for me to have the opportunity to present the preliminary data of our home registry. Is an Italian multi-center registry dedicated to evaluate the safety and the effectiveness of rotor access in limb occlusion after 𝗔𝗲. With the disclaimer, my disclosure. First of all, the rotor access is based on the Archimedes endless screw concept used in the past for water transportation. And if we apply this concept to the artery scenarios, of course, we can understand that it's possible to remove outside the body every type of fragmentable of thrombotic material. In rotor access, we have a still rotating helix that rotates in a single lumen catheter. This helix has a coaxial central lumen for the guide wire. So the combination of this rotating helix and the rotating tip allows the full function of Rotarex, because the rotating tip without blades is able to produce a vortex and then to detach, to fragment every type of thrombotic material, and the rotating helix is able to aspirate and to transport outside the body these materials. The rotor access exists in 3 different sizes, the 6, 8, and 10 French for different vessel diameter, and then the 6, the smallest one for a vessel between 3 and 5, the 8 for a vessel between 5 and 8, and the biggest one, the 10 French, for vessel between 7 and 12 millimeter. The aspiration, the power of aspiration is different. If we consider the 6 French is around 45 milliliter per minute, is almost the double in the 8 French, is 140 milliliter per minute in 10 French. We know that is contraindicated in cerebral, coronary, and cardiopulmonary circulation. So the most important clinical benefit of Rotarex use are that using Rotarex we can treat a wide range of arteries from 3 to 12 millimeter. We can treat not only the native artery, but also the in-stent restenosis, bypass occlusion, dialysis graft occlusion, and we can remove every type of thrombotic material. Then, in my opinion, it's really important that using this device is possible to remove not only the acute thrombotic material, but also the subacute and the chronic thrombotic material. So, as I said before, the 4 scenarios where we can use this device are native artery. The mandatory concept of the use of Rotarex in native arteries is to try to remove all fragmentable material, all thrombotic material, in order to unmask the culprit lesion, because a long occlusion usually is due to a short subocclusion, short stenosis, and then after the use of Rotarex, we can focalize our treatment on this lesion, and the published paper about the use of Rotarex in native artery show well that using Rotarex is possible to reduce the use of stent, in case of stent used, to reduce the length of stent. Rotarex can be used also in in-stent restenosis, in-stent occlusion. As I said this morning, the complex in-stent restenosis, then the 𝗤𝗏2 lesion, and the complete occlusion, the 𝗤𝗏3 lesion. For this type of lesion, the best treatment is yet to come, and the most recent papers show that probably the best treatment is the debulking, the combination of the debulking with the drug delivery system. the debulking in order to remove the thrombotic material, the intimal hyperplasia, and then to improve the drug delivery at the level of the smooth muscle cells, and also to avoid embolization in case of a total occlusion. But Rotarex is also possible to use this device in bypass occlusion. We are vascular surgeons, then we know well how distressing is to the 𝗔 bypass surgery in patients with many previous surgical revascularization in the same leg, and also the 𝗔 bypass surgery has pure long-term result in case of not available autologous vein. So using this device is possible to treat every type of bypass, then above, below, the knee bypass, prosthetic, biosynthetic, and vein bypass, like in these cases. So, in this part of my presentation, I would like to underline the most important steps that we have to keep in mind when we use this device. This in order to improve the safety, the effectiveness of this device. The first thing is that we have to cross the lesion in an intraluminal way. We have to sure that we stay in intraluminal, and then we have to spend time to use some different support catheters, some different guide wire to cross the lesion in intraluminal. In case of impossibility to go in antegrade, we can go directly through a retrograde puncture of the native artery, of the stent, or of the bypass, in order to be sure to be into the true lumen. After crossing the lesion, of course, we have to choose the right size of the device, and then based on the diameter of the arteries. About the sheath, usually when we work in antegrade, we use the sheath one-to-one with Rotarex. But when we work in crossover, usually we prefer to use a sheath, a reinforced sheath, 1 French bigger than Rotarex. This to avoid the kinking at the iliac bifurcation and to obtain a better passage of the device. And again, when we work in retrograde, then like in iliac occlusion or like in iliac limb occlusion after river, usually we use sheath 1 or 2 French bigger than Rotarex. This in order to maintain a continuous infusion of a heparinized solution, because we know that Rotarex has to work with a continuous lubrification. So about the heparinization, usually we give 100 units of heparin, AV heparin per kilo, but in order to obtain an ACT higher than 250 seconds, this to avoid the thrombosis of the helix. Usually we use a specific guide wire for Rotarex. For the 6 and 8 French is a 1/8 guide wire, a really supportive guide wire. For the 10 French is a 2/5 guide wire. Now, after placing the specific guide wire, we are ready to start with the procedure. We place the tip of the catheter into an open vessel, few millimeters above the occlusion, and we start with rotation in this point. This in order to activate the aspiration. And then we go through the occlusion with this typical movement, slowly, not more than 1 centimeter per second, in order to obtain the maximum removal of all fragmentable material with this typical fore and back movement. A mandatory marker of an effective aspiration is to see during all the procedure a blood flow into the collecting bag outside the body. This is really, really important to avoid a distal embolization when we arrive at the end of the occlusion. Again, to reduce the risk of the distal embolization, I think is really important at the fourth passage of the device to stop the procedure 1-2 centimeter above the last part of the occlusion to maintain a distal cap, and then to inject contrast medium to see in retrograde way the effectiveness of our treatment, and then only we are sure to have removed all thrombotic material to go through the last part of the occlusion really slowly, because at the time of the flow restoration there is an high risk of the distal embolization. And again, to reduce the risk of the distal embolization, I think a really important maneuver is to withdraw the device, maintaining rotation and then maintaining aspiration. So this, in order to summarize all the steps and the tips and tricks that we have to keep in mind when we decide to use Rotarex. In the second part of my presentation, we are focalize our attention on a more specific use of Rotarex, different than the previous presented cases. The use of Rotarex in patients with an iliac limb occlusion after EVAR. We know that the Achilles heel of EVAR are the secondary intervention, the late complication, and the iliac limb occlusion is the third reason of this secondary intervention. The percentage range between 0 and 10% in literature usually is unilateral, but in some cases we can have a complete thrombosis of the graft, and related with another negligible mortality on limb loss. We know that there are some different group of factors that are reason of the iliac limb occlusion. On one end, we have the artery, anatomical artery factor, then the tortuosity, the small arteries, the kinking of the arteries. On the other end, the factors related to the device, and then the thrombotic material into the device, the migration of the device, again, the small size of the device. But in summary, the combination of the anatomical and graft factor are reason of the graft kinking that in more than 40% of cases is the reason of the iliac limb occlusion. About the clinical presentation, usually we can have chronic ischemia ranging from the intermittent claudication to the CLTI, but in around 40% of cases we can have also an acute ischemia. If we decide to treat this patient, we can use different approaches: open, hybrid, surgery, totally percutaneous approach, or in some cases, in a symptomatic or less symptomatic patient, we can be conservative. These meta-analyses show well that right now the most used approach is the open surgical and hybrid approach in more than 60–70% of cases. And actually the endovascular approach is underused in less than 20% of cases. But if we decide to use an endovascular approach, we can choose between some different possibilities. Of course, the local thrombolysis, the other thrombectomy devices. But I think the limitation of this are the possibility to treat only the acute occlusion and not the subacute and above all the chronic occlusion. This is the reason why we decided to use the mechanical arteriothrombectomy device in order to treat every type of iliac limb occlusion after EVAR. Now just two cases to better understand the effectiveness of this device. This is a case by Giacomo Isernia from the Perugia Hospital in Italy with a right limb occlusion. after inflation of the balloon in the other side, this is a rescue maneuver to avoid the shift of thrombus on the other side. He performed a recanalization using a 10 French rotarex with this final result. This is another case. This is from my hospital. It's a chronic occlusion, over 6 months occlusion of this right iliac limb. We use a Bernstein catheter and a stiff 𝗔𝗏 guide wire to try to cross this occlusion. It's quite difficult because it's a chronic material, but at the end we are able to regain the true lumen into the body. And then we place a 12 French flexor sheet. Again, we inflate a balloon in the contralateral side, a rescue maneuver. And we place a 12 French sheet to maintain this continuous infusion of heparinized solution and to work with an effective lubrification. And then we go through the occlusion with this typical movement, then really slowly to try to remove, to obtain the maximum removal of all fragmentable material. Eventually, like in this case, we can push a bit the sheath in order to obtain a better support in the proximal portion of the occlusion, and then to go again with this movement through the occlusion. And this is a 10 French rotarex until we arrive at the level of the body of the graft. After this, we did an angio. We have a new lumen, but with a residual thrombus. Then we decide to perform a relining in order to obtain an 𝗟liche surface. And this is the final result in this patient. So, just to the last slide about this Rome registry. The Rome registry is an Italian multi-center registry with the data collected in 5 hospitals in order to try to evaluate the safety and the effectiveness of rotarex in this patient. We collected 23 patients with an iliac limb occlusion. All these patients male with the typical comorbidities for this type of patient. Only one case with an acute limb ischemia, all other cases with chronic symptoms ranging from the intermittent claudication and CLTI. No bilateral occlusion, just unilateral occlusion, but in 45% of cases, a concomitant occlusion of the ipsilateral external native iliac artery. About the procedural time is, the median procedural time is 80 minutes, and the blood loss is acceptable around 200 milliliter. Around 90% of patients treated in local anesthesia, and again, around 80% of patients with a totally percutaneous approach using at the end the percutaneous closure device. We did a surgical cut down just in 4 cases. Of course, the most used device is the 10 French, but in 4 cases we used the 8 French in patients with a concomitant occlusion of the external iliac artery. This in order to be less aggressive in this dangerous area. And in more than 50% of cases, 2 passages were enough to obtain a recanalization. These are all the adjunctive maneuvers that we performed after the recanalization. And regarding the result, the immediate result, no deaths related to the procedure. We were able to recanalize all 23 limb occlusion. Only one major complication, a perforation of an external iliac artery fixed during the same procedure, placing a covered stent. Regarding the later result, there are no deaths in this series. no reintervention, no open surgical conversion to reocclusion during the follow-up, but due to the asymptomatic or less symptomatic patient in Rutherford 1 class, we decided not to retreat this patient. Then, just to conclude this very long presentation, the Rome registry, despite of course all its limitations, showed that Rotarex could be considered a safe and effective treatment in this type of patient with no death, no limb loss, and just one major complication fixed during the same procedure. Thank you a lot for your time.
Thank you, Dr. Bruno, for this very illustrative and very ultimate technique in treatment of limb occlusion. We'll open the discussion for the floor. If we have any question, we have a question from Dr. Ahmed Said, please.
Yeah.
Route. So whenever I manage to cross a lesion through a subintimal route and I feel I need some debulking of the lesion, am I allowed to do it with the Rotarex or it's contraindicated?
Well, we have to stay intraluminal. Then usually, of course, when we treat acute and subacute occlusion, probably the guide wire stay intraluminal is quite easy. Yeah. In chronic, it's not so easy. And then in case we are not sure to stay all the length of the occlusion in intraluminal, you can use Rotarex, but when you are in subintimal or you think you are in subintimal space, to stop, to cross this area with the engine, the stop engine, and then to retreat the other. But of course, I think in very long chronic occlusion it's really difficult to be sure, and then probably is not indicated in this type. In my country, this device is not reimbursed. Then this is a big problem. And I try to use this above all in subacute patients where the Fogarty is not possible, the thrombolysis is not effective, and PTA is dangerous with an high risk of embolization. Then I think the subacute, the typical occlusion, 1 month, 2 months occlusion is the best indication in native artery.
So I should plan myself to be as much as I can interluminal, so to leave the choice open till the end. The second question is regarding the distal cap. You said we proceed until just above the cap, and then we withdraw the catheter. Yeah. And could you please elaborate again technically what we should do step by step in this last critical point, because this is what we are always afraid of, having a successful use of the device and at the end trashing in the tibials.
Okay. The first thing is that when I use Rotarex, using Rotarex, I never placed a distal filter, okay? Because it's a thrombectomy device, first of all. Then I think the aspiration is really effective, better than the other atherectomy device. But of course, the risk, and also in the publication, the risk of distal embolization is around 5–6%, okay, in the published paper in literature. In my experience was the same, probably a little bit worse because 7%. And I thought, but when I performed the first passage, I'm not sure to have removed all the material at the first passage. And then I decided to go until 1 centimeter with the device above the last part of the occlusion, to stop. I have just the guide wire that crossed the last part, to place a Bernstein catheter on the guide wire and to inject contrast medium to see in retrograde, because the contrast medium goes in retrograde, not in antegrade. In retrograde, the effectiveness. When I sure it's possible also, but it's expensive to use HIVOS to evaluate this. When I sure that I removed all the material, okay, I use another time Rotarex. I go really, really slowly through the last portion, last part, because of course at the time of when I open the last cap and the flow start, if there is a thrombotic material, I have the embolization. With these tricks, I reduced the risk of embolization, and now it's around 3%, but the risk exists, of course.
Thank you very much. I have enjoyed the talk. I just have a question about the Rome trial. I was just thinking, do you think it worth to make a phase 2 of this trial, like a randomized trial, to compare your technique versus fem-fem bypass and have a primary endpoint as regards success rate and patency, and secondary endpoints including all in-hospital complication and costs, to come to a conclusion when to use which? Thank you.
Yes, probably is a really good idea. We started during the COVID period with my friend to collect this data, and probably the next step is to compare, because now are just I don't know, it's not a pilot study, but just to evaluate the safety and the effectiveness. Of course, are not the definitive conclusion. We have to compare with the other, also with the other devices on market, or the surgery, because surgery is the gold standard in this case. Then, yes, just the preliminary data, this.
Excuse me, Dr. Bruno.
Yeah.
Go, Dr. Mata.
Okay. We have to go with the Rotarex with the bloodstream, but in the last case you have presented in the 𝗖𝗃 occlusion, it was against the bloodstream. You come from below and go upwards. Can you elaborate this, please?
The stream from to go from below to above.
You went from distal to proximal.
Yeah.
Against the bloodstream, against the flow of the blood. You
Yes,
gave from below upwards.
Yes. When we work in this situation, it's similar when we work in the venous system. We work without flow, okay? Then the mandatory thing is to work, using Rotarex, is to work with flow.
Yes.
Then when we work in retrograde, we work without flow. And then this is the reason when it's really, really important to maintain a continuous lubrication of the device, to avoid the thrombosis, and to remove the material through the devices. And then it's possible to go from below to above in retrograde without a blood flow. But we have to place a sheath bigger than Rotarex, and to maintain a continuous inflation around the device. This is...
Yes. Is the pre-dilatation is contraindicated before the use in case of the 𝗖𝗃 occlusion? If you want to pave the way for your Rotarex to go upwards through pre-dilatation, and you can use the flow in an antegrade manner.
Yes. Okay.
Could it be possible or not?
Yes. I avoid predilatation in this patient because usually it's a fragmentable material, and then there is a risk of embolization. I try to go in retrograde without blood flow to remove all fragmentable material. After two passages, as I showed before, I didn't remove all the thrombotic material, but probably the fragmentable material. The residual material around the previous endoprosthesis was an hard material, and then I place I performed the relining. To perform a predilatation, I think there is a risk of distal embolization. This is the reason why I don't like, also when I work in antegrade. I start with Rotarex. I try also when I cross, I don't know, an SFA acute occlusion or subacute occlusion, I try to cross just using the guide wire and not using the Bernstein catheter, because with the Bernstein catheter it's possible to obtain an embolization. This is because I didn't perform the predilatation.
Yeah, I think Dr. Bruno here, Dr. 𝗏𝗏𝗏 is introducing maybe a new technique, how using the Rotarex instead of having a femoral access to have a subclavian access and put a long cheese and go from up down. It will be more safer and with the bloodstream. This is a modulation of the technique. If this is possible and feasible to do this?
Yes, no, it's possible, of course.
Would it be more safer to have a subclavian access instead of a femoral access, retrograde approaches?
I'm not sure. I'm not sure, but it's possible. Yes.
It is. Have you? Last question. Have you thought about post dilatation instead of doing relining, because you are putting metal inside metal? It's too much for this. Because of there is a concern about the patency in the future.
Yeah, this of course, but in 85% of cases, the idea of use of Rotarex in this patient is to, like in native arteries, to remove the thrombotic material, to open a new channel, and to try to understand the reason of the occlusion, and to try to fix this reason. Then in 85% of patients we place a stent to correct a kink or something like this. In 60% of cases, due to a residual thrombotic material, chronic thrombotic material around the limb, we perform a relining. Of course, it's material in material, but the reason is to avoid thrombotic material and then the risk of an acute thrombosis. We didn't have problem with this. Of course, material in material is not a good idea like when we perform a relining of SFA or POP stent.
Yes, thank you.
Thank you, Dr. Ahmed. Please.
Thank you for this presentation. I would like to ask, does the occluding material inside the iliac limb of 𝗍𝗏 differs from the occluding material in the bare metal stent like SFA? And does it make difference in your technique?
No, yes, of course, it's completely different, because in case of SFA stent, if it's a bare metal stent, not covered stent, it's a hyperplastic material, near intimal hyperplasia with a small thrombotic central portion. In this case, it's different because it's a covered stent, then no hyperplasia, but all thrombotic material. But the technique is the same. Probably it's a bit easy to remove the thrombotic material than the intimal hyperplasia. But if you work well, it's possible to obtain also an effective lumen gain removing hyperplasia. But of course, in the iliac limb, I think it's easier to obtain a good result at the end. The only problem is because Rotarex is able to work in a 12 millimeter in diameter vessel, and then in some cases it's a bit small for this vessel. Then we can use some tricks to improve a bit, moving a bit the device on the guide wire, and then to obtain to gain 2-3 millimeter, but 𝗟trix is not indicated for a vessel bigger than 12 millimeter.
Did you deploy stent inside this iliac limb before?
After the rotarex?
After rotarex?
Yes. In 85% of cases, we place or a stent to correct a kinking, or a stent to prolong the limb into the external iliac for a problem into the external, or a kissing stent of the bifurcation to correct something. There is a table in my presentation with a lot of procedures that we performed to try to solve the problem that is the reason of the occlusion.
Thank you.
No.
Thank you, Dr. Bruno. Last question. Yeah, at the meta-analysis, you showed that more than 50% of the limb occlusion after EVAR is done surgically, and less than 20% only done by endovascular maneuver. Would you think that when we have getting more familiar and more confident in the technique of using rotarex, this percent will change?
Good question. I'm not sure with my answer about this. Yes, probably we have to improve a bit our technique, our approach using rotarex in this patient. But yes, I think we have work in this direction, because these initial results are good, and then I think we have to try to work to improve a bit this result, to change probably something in this technique, and to choose eventually other ways to improve this result.
Do we need a bigger device from the company, or 10 French is enough?
No, I want a smaller one for the tibial vessel.
Thank you, Dr. Bruno, for this very rich discussion.